Assalamu alaikum, dear students. To this session, which is a second session specifically for the hand and fingers for injuries. Previous session में हमने discuss किया था कि about the prevalence and general distribution of the hand and finger injuries. Then we talk about how to take the history and what is the importance of history and what questions should be asked in the subjective examination of the history. Then we discuss the common and least common causes of the hand complex pain, each and every one, and metacarpal fracture, phalanx fracture, and so on. Then we discuss the range of motion and other specific tests which we can use during our examination. These were the discussion on the, the extensor compartment on the dorsal side and its association with the listed tubercle or the dorsal tubercle. We discussed the snub bugs, the anatomy of the snub bugs, and its association and importance with the scapite fracture, and how we can assess the scapite fracture through these anatomical snub bugs. What are the structure they are passing through this snub bugs, and is there any chances of the compression and damage to these structures, which are the deep branch of the that radial artery and as well as the superficial branch of that nerve. So ये आज हमने डिस्कस किया था इसके बाद हम डिस्कस किया the different tests which we can use during the physical examination during the objective examination, which include the active movements of the thumb, the resistance movements of the tendons, and then some special tests. So today we will start from here the investigation. So in investigation, we can use the routine radiographs, including the PA views as well as the lateral and oblique views. एंड जितनी भी इंजरीज होती हैं उनको कास्ट से पहले भी जो है रेडियोग्राफ करनी चाहिए एंड देन आफ्टर द कास्टिंग जो है या आफ्टर द रिडक्शन जो है भी वहाँ पे उसकी जो रेडियोग्राफ होनी चाहिए स्पेसिफिकली इफ देयर इज डिसलोकेशन, क्योंकि डिसलोकेशन में अगर हम वहाँ पे इसको रिड्यूस कर रहे हैं एंड देन इसको हम ट्रीटमेंट प्रोटोकॉल पे डाल रहे हैं, तो इसलिए पहले हमने इसको से फ्रैक्चर है इसकी अवेलेबिलिटी इसको एक्सक्लूड करना है एंड दैट्स व्हाई बिफोर रिडक्शन अ डिसलोकेटेड जॉइंट द रेडियोग्राफ इज वेरी इंपॉर्टेंट. इसी तरह जब इसकी रिडक्शन हो भी जाती है तो उस पोस्ट रिडक्शन भी जो है हमने यह इसकी लेनी होती है, ताकि समटाइम इस तरह होता है कि पास हमें मौका ही नहीं मिलता एट द जो थेरापिस्ट वहाँ पर होते हैं या उन जो पेशेंट है और तीट है उनकी रिडक्शन जो है ऑन द साइट ऑफ इंजरी ही हो जाती है, तो प्री रिडक्शन अगर आप उसकी अवेलेबिलिटी नहीं होती तो हम पोस्ट रिडक्शन भी ले लेते हैं. और पोस्ट रिडक्शन अगर हमने प्री रिडक्शन दिया भी होता है तब भी जो है ये पोस्ट रिडक्शन जो है ये बहुत जरूरी है. नाउ इसकी ट्रीटमेंट इंजरीज में अगर देखा जाए तो ये हैंड जो है दिस इज इन्वॉल्व इन नंबर ऑफ एक्टिविटीज इंक्लूडिंग दैट ग्रास एंड फाइन मोटर एज वेल. इसलिए ये जो फंक्शनल हैंड जो इन एक्टिविटीज के जरूरी होता है उसके लिए द स्टेबिलिटी, द मोबिलिटी, सेंसिटिविटी एंड द अनअवेलेबिलिटी और द लैकिंग ऑफ पेन जो है ये बहुत जरूरी है, तब जाके जो है हैंड एक फंक्शनल हैंड कहलाएगा. If mobility and range of motion is lacking or there is some disturbance of the limitation of the range of motion, yeah, stability due to some ligamentous injuries, if there is some sensitivity problem or if there is pain in any part of the any joint of the hand, that may be because of the articular origin, non-articular origin. In all cases, we can't call it a functional hand. So the main aspects of the treatment and objective is to make the hand functional without any pain. Conservative rehabilitation, that is very crucial and important just to regaining these mobility and these pain-free activities. But as we know that the hand is made up a number of complex structures that may include the various joints, the ligaments, the tendons, and nerves. So that's why the overall treatment and rehabilitation of the hand is a little bit complex. यहाँ पे हमने जब ट्रीटमेंट करनी होती है, सो वी शुड बी अवेयर ऑफ द इंफॉर्मेशन एंड स्विनिंग, और अमूमन ये प्रेजेंट भी होते हैं। एंड तो सबसे पहले हमने इसका भी जो है थोड़ा सा रिहेबिलिटेट करना है अबाउट टू रिड्यूस द स्विनिंग एंड इन्फ्लेमेशन ड्यूरिंग द इन्फ्लेमेटरी फेज। द थेरापिस्ट मस्ट एम टू रिड्यूस एडिमा, और एडिमा के डिफरेंट एक्सरसाइजेज होते हैं um, जो, और जब तक इसकी एडिमा जो है कम नहीं होती तो ऑब्वियसली we can't have that functional hand. So the knowledge of that different phases of the inflammation, that is really necessary. As we can see here, there are the different phases of the wound healing, including the bleeding, and this is the inflammatory phase, which we have discussed in the previous slide. That the main aspect during the inflammatory phase is just to reduce the swelling and edema and the accumulation of fluid which has been there at the injury site. इसको थोड़ा सा जो इस पर कंसंट्रेट देना चाहिए कि वहां पे जो है स्वेलिंग ना हो, फिर वहां पे और जो all other sign of the inflammation including the pain, heat and redness, ये सब जो है ना हो। तो जब वहां पर ब्लीडिंग हो जाती है तो ब्लीडिंग से obviously there will be inflammation. After the inflammation, the next stage, which is also known as the proliferative stage, which is also known as the regenerative phase, जहाँ पे inflammation थोड़ी सी कम हो जाती है, वहां पे सेल जिनकी इंजरी हो जाती है उनकी जो है प्रोलिफरेशन जो है वो शुरू हो जाती है, स्पेसिफिकली ऑफ दैट स्कार टिश्यू। एंड इसके साथ साथ उसमें यहाँ पे जरूरी बात यह है कि ड्यूरिंग दैट प्रोलिफरेटिव फेज थोड़ी सी एक्टिविटी जो है ये लिमिटेड रखनी चाहिए। और जब यहाँ पे एक्टिविटी को हम लिमिट रखेंगे तो ऑब्वियसली वी कैन यूज द सम स्प्लिंट इन दिस फेस। बट यहाँ पे हमने उसकी थोड़ी सी एक्सरसाइजेस भी जो करना है, मतलब इसको कंप्लीटली इमोबिलाइज नहीं रखना है। क्योंकि अगर हम इसको स्प्रिंट पे ना और कोई एक्सरसाइज ना दे, कोई एक्टिविटी, इसको रेंज ऑफ मोशन एक्सरसाइज ना दे, स्पेसिफिकली द एरोम द एक्टिव रेंज ऑफ मोशन एक्सरसाइज, तो ऑब्वियसली देयर मे बी वी विल अनएबल टू मेंटेन एंड टू रिटेन दैट रेंज ऑफ मोशन जो इस फंक्शनल हैंड के लिए जरूरी है। द लास्ट स्टेज विच इज नोन एज द रिमॉडलिंग, वहां पे फिर हमने वहां पे डायनामिक्स इंस्टेड ऑफ द सपोर्टिव स्प्रिंट, the therapist then they should use the dynamic in serious sprint. सपोर्टिव स्प्रिंट और डायनामिक स्प्रिंट में यही एक है कि वहां पे सपोर्टिव स्प्रिंट में वहां पे थोड़ी सी जो है रिस्ट्रिक्शन होती है, डायनामिक में द पेशेंट कैन डू ऑल टाइप ऑफ एक्सरसाइजेस। सो इसकी यहाँ पे एक्टिव एंड असिस्टिव एक्सरसाइज के साथ साथ जो है वहाँ पे स्ट्रेचिंग एंड इलेक्ट्रोथेरेपेटिक मोडलिटीज जो है या हीट थेरेपी, ये भी यहाँ पे हम यूज कर सकते हैं। सो दीज आर सम ऑफ द रिकमेंडेशन ड्यूरिंग द inflammatory phase, the proliferative or the regenerative phase, and the remodeling phase. So, how we can control the edema? So, the patient splint should be in the position we call as the intrinsic plus position. This is the hand we can have जहाँ पे almost there is wrist में थोड़ी सी जो है यहाँ पे extension हो गया almost 30 degree, while the MCP joint we can see here there should be at least up to 60 to 70 degree of that friction, as well as the PAP and the DAP. They should be straight, they should be extended. When they are straight, so it means they are at 0 degrees. So that position, when the wrist is extended, the MCP is up to 60 to 70 degree flexion, and all the PAP, DAP, they are in the straight, they are in the extension position, the neutral position, in the 0 degree extension, and there is should be some abduction of the thumb. In that case, this position is actually known as the intrinsic plus position. इसके अलावा जो इडीमा है उसको कंट्रोल किया जा सकता है डिफरेंट टाइप्स ऑफ स्प्लिंट, एज वेल एज द कंप्रेशन बैंडेज हम यूज कर सकते हैं, क्रायोथेरेपी से हम कर सकते हैं, एंड ऑब्वियसली वी कैन एलिवेट इट टू द एलिवेशन जो है, एंड सम थेरापेटिक अल्ट्रासाउंड वी कैन यूज फॉर द दैट रिडक्शन एंड कंट्रोल ऑफ द edema. During the exercise, the splints they should be removed, and so they should be used on the on-off situation. During the exercises, the splint should be removed, and when there is no exercises, then the splints they can be on. First, making exercises they should be used because they can help in the reduction of the that edema. And as we have discussed, the elevation has a positive impact on the control of edema. So during the exercise, the hand should be kept elevated. So these are the two types of position in the hand. This is actually known as the intrinsic plus position, and this is actually known as the intrinsic minus position. So intrinsic in the intrinsic minus position, instead of keeping the PIP in the in the flex position, in the extended position, they should again be kept at the DIP. Sorry, they should keep in the extended position. Similarly, the therapist can just prescribe the different gliding exercises just to reduce the edema, and which may include the keeping the hand strand, then the hook fist, then the full fist, and at the end the straight fist. So repeating again and again all these exercises, these they can help in the reduction and control of the edema. So these tender gliding exercises they have a very positive impact on the edema reduction. As we discussed, the compression band they can be used, and of different size they are available. They can be available in 4 inches diameter. They are available in 1 inch diameter. But that 1 inch is more appropriate for the fingers, as the 4 inch they will be too broad for them. So the 1 inch that is very appropriate for the that finger. अगर यहाँ पे साथ साथ हम इसी को जो टेंडन ग्लाइडिंग एक्सरसाइज है ये इस बैंडेज के साथ दे so they much will help in the reduction of the edema. Similarly, the therapeutic modalities, electrotherapeutic modalities like the therapeutic ultrasound, they can also use to reduce the swelling and to control the edema. Different exercises, including the ecto assisted or resisted exercises, that can be used during this phase. And if there is situation like the tendon laceration or the strain or the rupture of the tendon, then different protocol can be used, which can be determined, which can be planned after the technique used in the surgery and then through the discussion with the surgeon. A full description of the protocol is beyond the scope of this lecture, so that's why we are not going in detail of those that what different protocol that can be used into in the rehabilitation of these hand and finger and these MCP, PAP, DAP injuries. Some general exercises which can be used during these digit injuries. They are the blocking exercise, the composite flexion exercise, the extension exercises, and the active assisted exercises. The blocking exercise they are very important if we are going to just to rehabilitate or just to do the active range of motion exercise or the passive range of motion exercises in a specific joint while we are going to restrict the movement at the other joint. For example, if we want to mobilize the PIP and we want to block or restrict the DIP, so then to isolate that, we can do these blocking exercises. Similarly, if we are involving all the joint at once, then these are known as the composite flexion exercises, like we do in the tendon gliding exercises, extension exercises, and the active assisted resisted exercises, in which the patient take a joint through the full range of motion, and then the therapist assist in gaining some slightly greater range with overpressure, that is from the available range of motion. So these are the different exercises, specifically the blocking exercises. Body tapping is very important and it can be used in this situation, and they have a very positive role because the one which is sound or which is uninjured, they will help in the movement of the injured one. So that is one of the commonly more used method as well. The uninjured digit provide additional stability and that help in the movement and that encourages the full range of motion of the injured one. In acute phase of injury, static sprint are used to reduce edema. A dynamic sprint they can be used in the latest stages as we discussed in the previous slide. But with the dynamic sprinting, that is very important that the sprint should be worn with less tension and specifically if they are wearing for a long period. These are the general classification and difference between the static orthosis and the dynamic orthosis. In the dynamic orthosis, there is some permission and there is some availability of the range of motion. They permit movement. These are sprints that provide a dynamic force. They are generally using energy storing material like rubber, spring, rubber band, spring steel, the wound coiled wire, or the plastic with memories. It means there is some elasticity and they can help and to permit some movement. On the other hand, the static orthosis, they are the orthosis who do not permit any motion and they are referred to as resting or positional splint as well. They are commonly fabricated from a low temperature thermoplastic material, but if a permanent orthosis is required, high temperature, the copolymer plastic, they can also be used. This is the body tapping. This is the one of the orthotics device, dynamic finger extension splint. Now, if we keep seeing this, there is blocking of the PIP, while at the same time there is extension of the DIP as well. About then toward the fractures of the different metacarpals. Initially, we will talk about the fracture of the first metacarpal, specifically the base of the first metacarpal, which is very common in sports or in activities where there is use of the hand, or when there is just like in the boxing or the other activities. So there are different, as it is common. So there are different types of these base of the first metacarpal fracture. They can be the extra-articular, they can be complete articular, or they can be the partial intra-articular. The fracture which are extra-articular, there can be of two types. They can be transverse fracture, uh, mm, which is somehow almost 1 centimeter distal to the joint, and if they are extra-articular, they can also be of the oblique fracture. So that depend that what is actually the orientation of the fracture. The extra-articular mean the joint surface is not involved, but if they are transverse, so they can be that just parallel to the metacarpal joint, and if they can be also oblique. Those who are partially intra-articular, they are known as the Bennett fracture, and those who are the complete intra-articular, they are known as the Ronaldo fracture. In the Bennett fracture, usually there is dislocation of the first carpometacarpal joint. And these both are the intra-articular, the Ronaldo and Bennett, but the Ronaldo, they are the complete intra-articular and they are the partial intra-articular, while these transverse, this is just parallel to the joint surface. These are transverse and these are oblique and both types of the that extra-articular. The transverse fracture near the base of the first pentacle result in the thumb line flexed across the palm. Reduction of this fracture involves extension of the distal segment of the metacarpal. This fracture can be immobilized in a short arm speaker cast. On the other hand, the Bennett fracture, that is a dislocation of the first carpometacarpal joint, is a result of the axial compression when the first metacarpal is driven proximally, shearing off its base. So these are some of the radiographs. There is, we can see here, a parallel to the that surface that is at the base and the proximal end of the metacarpal. The first metacarpal, this is the transverse fracture, and obviously, there is some later stages we can see here that the space between the two parts that is being somehow filled between, that is a healing stage. We can see here that is partially, this side is completely okay, but on the inner side there is a fracture, and this is known as the Bennett fracture, which is the partially intra-articular fracture. And here is entire surface is being involved. Here we can see this is the base structure, complete intra-article of the first metacarpal. This is the proximal filling. This is the distal filling. This is the second metacarpal. So this complete disruption of the intra-articular surface, this is known as the complete intra-articular and known as the Ronaldo fracture. Fracture of the other metacarpal, they are not so common as common they are in the first metacarpal. But they can also be happen at the same mechanism when there is a result of punch. Among these fracture from second to fifth, the commonly seen if they are present in the medial two metacarpals, the fourth and the fifth metacarpals. And if they are present, they are commonly known as the boxer fracture. So this is very important, and that which two metacarpals they can commonly be seen and can commonly referred as the boxer fracture. They are the medial two one, and this is the fourth and fifth, which is the metacarpal on the ring side and on the pinky. The fracture is usually accompanied by the considerable friction deformity of the distal fragment. However, this deformity results in the surprisingly little functional disability. So we can see here there is फ्रैक्चर इन द मेटाकार्पल और जितना ये प्रॉक्सिमल होगा उतना जो है ज्यादा जो है सपोज दिस इज द मोस्ट डिस्टल दिस इज जितना डिस्टल होगा उतना ही जो है ये नकल जो है कम जो है ये ड्रॉप होगा जितना प्रॉक्सिमल होगा उतना ही जो है द नकल जो है ये ज्यादा ड्रॉप होगा सो इट मीन more proximity and more dropping of the knuckle. There may be, if the fracture is present in all the four, so usually the extreme metacarpal, which is the second and fifth, they may have the unstable fracture. We can see here, this is that unstable, there is unstable, but here there is also two fracture is the third and fourth. But as the third and fourth, they are connected on the both side by those ligaments, which are known as the deep transverse intermetacarpal ligaments, while the fifth one and the second one they are connected only on one side, while on the other side there are no such ligament. So that might be the reason that why the second and fifth usually they are revealing the that unstable fracture, while the two, the third and fourth, usually they have the stable fracture. We can see here from this image. अब आते हैं towards the that fracture of the phalanges यानी more distally हम आएंगे from the metacarpals और यहाँ पे अगर बात कर ले तो usually they are very common among those in those sports or in those activities जहाँ पे ball handling जो है इन्वॉल्व होती हैं और these या वहाँ पे सपोज क्रिकेट में हो सकते हैं when the person is going to catch the ball और बॉल जो है that hit the tip of that digit या यहाँ पे जोर से जो है उसको लग जाती है बॉल एट द मिड ऑफ द डिजिट सो वहाँ पर जो है न सिर्फ ये कि फ्रैक्चर ऑफ द पेलेंज हो सकती हैं बट समहाउ वहाँ पे डिसलोकेशन भी हो सकती है द फ्रैक्चर ऑफ द प्रॉक्सिमल फेलेंस अब पहले हम प्रॉक्सिमल की बात करेंगे और फिर उसके बाद हम जो है डिस्टल की तरफ जाएंगे so proximal phalanx fracture they mostly if they are present they may lead to the functional impairment due to the extension and flexor tendons they are coming into contact with the Achilles and exposed bone. To control and reduce and treat these fracture under the ring block, the MCP joint should be flexed to 70. The PAP joint is then flexed and longitudinal traction applied in line with the shape of the digital fragment to the opposite fracture. What we mean by the ring block? A circumferential ring of the local anesthetic injection they are applied just to block the nerves which are supplying this digits. So in all direction in the ring there can be inject. So you can see here the nerves they are present in all directions. So the injection of that anesthetical injection is injected in all directions to just to block the entire ring and glad circle around this bone. That is known as the ring block. As you can see here, this is the first metacarpal, this is the second and third, fourth, and fifth metacarpal. These are the knuckles, these are the MCP joints. This is the proximal phalanx, and we can see here oblique unstable fracture of the um, index finger proximal phalanx. The fracture is immobilized with the wrist slightly extended and the 70-degree flexion if the MCP joint, like we discussed previously in the intrinsic plus position, where the wrist are somehow in the dorsiflexion or extension, and the MCP they are flexed to the 70-degree. These fractions they require the radiographs on the weak basis and to ensure that actually their movement has not occurred and ensure that they are in the normal situation and the situation is normal and under control. If there is a requirement of the further stability, so buddy tape can be used just to enhance the stability. The splint is then removed after 3 to 4 weeks, and the body tapping will be continuous. If there is still some instability in the fracture and the stable or the fracture, they are still unstable, and so there may be need of some surgical intervention as well. The middle phalanx fracture, usually they can be of both types. They can be transverse or oblique, but as compared to the proximal phalanx, the healing process of the middle phalanx they are too slow. The center slip of extensor tendon attached dorsally. This is very important. That the extensor tendon that attached dorsally on the base of the bone, and the flexor digitorum insert on the ulnar surface more distally. Thus, because of this anatomical situation, the fracture distal to the flexor tendon attachment, they show friction of the proximal fragment and extension of that distal fragment. So we can see here, this is the dorsal surface, this is the extensor tendon. They are attached at the base of the middle phalanx, while the flexor tendon they are attached somehow distal on the shape of the volar surface of the phalanx. So if there is a fracture proximal to this attachment of the flexor tendon, so then there may be a friction and this flexion deformity. And if there is distal to this tendon, so there may be extension deformity as we can see here in this image. So fracture distal to the flexor tendon attachment show flexion of the proximal fragment. That is the flexion of the proximal and the extension of the distal fragment. So that each distal fragment is extension. Okay, so that is we can call as an extension a deformity. So these two, you can. This is the normal middle phalanx, the normal anatomy, and this is the proximal to the attachment of the flexor tendon on the ulnar side, and this is flexor distal to the ulnar attachment of the flexor tendon. So these both have different situation if they are proximal and the distal middle phalanx fracture. Here is some unstable fracture at the middle phalanx. I can see here there is oblique fracture at the ring finger middle phalanx. So these are the different classification of the base of the middle phalanx by the Sino et al. And in the article published by the Sino et al., they have described, they have enumerated that they can be classified into 5 types. So type 1 is when the fracture is on the older side only. Type 2 when the fracture is the base of the middle phalanx but is on the dorsal side. Type 3 when the fracture is present on both the dorsal and older side, and there may be somehow the unstable fracture, and the entire these both are the partial intraarticular. This is the complete intraarticular. Type 4 when this is extraarticular when the joint surface is not involved and the joint is in the that in the parallel or in the oblique, but that is extraarticular. Type 5, this is the severe form of the injury. When type 3, if we can see वहाँ पे भी जो है dorsal and ulnar fracture है, but वहाँ पे simple base involved है. But in the type 5, the length of the fracture is more than just in the base. It starts in the base, but it can extend through the distal as well. And again, this is more unstable than the type 3. So these are the five types of the sino et al. Classification of the base of the middle phalanx fracture. If the fracture they are stable, so they can be just treated by just immobilization through a splint in the intrinsic plus position, where the MCP they are flexed at the 70 degree and the PAP joint is at the 0 degree of flexion are in straight. So just we discussed in the plus position of the intrinsic plus position. When the splint is removed, range of motion exercises they should be started. And if the fracture is unstable or they are intra-articular fractures, so more than 25%, so then the best the recommendation is just to do the surgical intervention and the open with ORF, which is open reduction and internal fixation. So this is actually the guidelines. If the stable fracture is unstable and if the intraarticular surface is there and more than 25% of the surface is being involved in that fracture. Polar plate avulsion fracture they can occur during this injury if there is hyperextension as the mechanism. What are Euler plate? Euler plate, they are present on the Euler side and just to increase the congruency of the MCP joints and the interphalangeal joints. And these Euler plates, they are not only there just to increase the congruency, but they also limit and they also restrict the hyperextension and as well as they help in avoiding and help in the stopping or preventing the trapping of these specifically the flexor tendon in these MCP or the interphalangeal joints. So these all relate if there is hyperextension, so there may be some rupture as they are present on the older side. So जब older side यानी anterior side पे है palmar side पे वहाँ पे extend hyper extension हो जाती है. So they will be stretching. तो जब तक ये energy इसके control में है, so these hyper extension will be controlled. But if there is a forceful hyperextension and that is very in very quick time, so there will be rupture on the older side structure, specific structure known as the ulnar plate. And these injuries they are very common and usually ignored owing the unawareness of the potential consequences. Non-randomized control trials they have revealed that if their early mobilization with splinting found that mobilization has led to good functional outcome. So that's why they should be mobilized in the early stages. Now let's talk about the distal phalanx fracture of the hand. Usually these injuries they are there when there is crushing situation or when they are just jammed and when they just being hit by a strong solid structure like a bat, like a ball. Like we can see in cricket में बॉल जो है कैच कर रहा है और वहां पे तेजी के साथ बॉल उसकी तरफ आ रही है और वो कैच कर रहा है लेकिन वो सही जज नहीं कर सका हो और वो फिर बॉल जो है डायरेक्टली हिट द टिप ऑफ दैट डिजिट. सो वहां से न सिर्फ ये कि सिवियर इंजरी अब टू द नेल हो सकती है बल्कि वहां पे जो है डिस्टल बैलेंस की फ्रैक्चर भी हो सकती है चूंकि दे बहुत हाई एनर्जी के साथ आती हैं. So that's why most of the cases when they are the unstable joint, they are the and sometimes they are the non-displaced joints. A splint and compression dressing, they will just provide the enough and required treatment for these non-displaced fractures. Much of the pain associated with these fracture can be due to the subungual hematoma, as we have discussed. कि इस इंजरी में नेल इंजरी भी हो सकती है तो सबंगुल हेमेटोमा उसको कहते हैं कि जब नेल जो है इसकी नीचे जो है ब्लीडिंग हो जाती है सो द ब्लीडिंग इनसाइड द नेल ऑफ द finger, it is known as the subungual hematoma. So वहाँ पे अमूमन जो पेन ज़्यादा होती हैं that is just because of that bleeding inside the nails. Significant subungual hematoma required nail bed excision as the nail bed is often disrupted. We can see here this is two injuries. One is at the top of the distal phalanx, other is in the mid of the distal phalanx. In both cases, they should be treated and they are non-displaced fracture. On the other hand, we can see here this is the submugal hematoma. There is redness in the surrounding as well as there is some purple or blackish color under the nail bed, which indicate that there is severe bleeding inside the nail. This is actually known as subungual hematoma. अब आते हैं टुवर्ड्स द डिसलोकेशन फ्रैक्चर तो हमने डिस्कस कर दिया अब द मेटाकार्पल देन proximal fracture then the middle and then the distal fracture अब आते हैं toward the dislocation of the NCP joint. Dorsal dislocation of the NCP joint of the finger is uncommon, and if they are present, so they will be present in the thumb or the index finger, and they may be present more laterally than the medial ones. And if sometimes these dislocation is present in the index and thumb, they can be called as the irreducible dislocation. Because the reason behind that is this very important that the metacarpal is pushed through the ulnar plate. As the ulnar plate is being, this is an hyperextended injury, so that's why there may be rupture of the ulnar plate and the metacarpal head will push through the ulnar plate of the MCP joint and cut between the lumbrical and long flexor tendon with a buttonholing effect. This buttonholing effect is because of this buttonhole effect, these are called as the irreducible dislocation. बटन होने से मुराद ये है कि जो वहाँ पे मेटाकार्पल हेड है ये लंब्रिकल मसल्स एंड द लॉन्ग फ्लेक्सर मसल के दरमियान बिल्कुल जो है ये फंस जाता है एंड दैट इज एक्चुअली नोन एज द दैट presence in just entrapment of this presence of metacarpal head between these two muscles, the long flexor tendon and the lumbrical, that is known as the buttonholing effect. Suspect this injury when examination reveal hyperextension of the involved MCP joint with ulnar deviation of the finger overlapping of the adjacent finger, and because of this hyperextension, usually there is disruption of the other palate as well. If we talk about the dislocation of the PIP joint, so they are more common than the MCP joint. One thing why they are more common because the MCP joints they are supported by a number of ligaments between the head of the that metacarpal known as the intermetacarpal ligaments, but there is no such ligaments which are the PIP and DAP. So that's why the dislocation at the PIP they are more common, and specifically the dorsal PIP joint dislocation they are the most common. They use result from a hyperextension stress with some degree of longitudinal compression, such may occur in ball sports, or as we are going to hand catch something, जो कुछ हमारे हाथ पे इस तरह आ जाता है और हम कैच करने की कोशिश करते हैं तो वहां पे हमारी ये जो पीआईपी वगैरह है इसकी हाइपर एक्सटेंशन हो जाती है जिसकी वजह से देयर में भी डिसलोकेशन. This may produce the disruption of both the ulnar palate and at least one collateral ligament. और जब हाइपर एक्सटेंशन की बात आ ही जाती है तो obviously there would be a disruption, chances of disruption of the ओलर प्लेट. जरूरी नहीं है कि हर हाइपर एक्सटेंशन जो है ये ओलर प्लेट का नुकसान पहुंचाए क्योंकि ओलर प्लेट दे आर नॉट सो वीक कि ये सिंपल हाइपर यानी आप वहां पे देखिए 10 डिग्री तक आप अगर डीआईपी हाइपर एक्सटेंशन करते हैं आपको इवन पेन भी महसूस नहीं होगा. दिस इज जस्ट बिकॉज ऑफ दैट स्ट्रेंथ ऑफ द बट व्हेन देयर इज a quick and high energy trauma, so that a quick and rapid high energy hyperextension there because the disruption, the rupture of the ulnar palate on the ulnar side. Reduction often occurs on or beside the playing area. Reduction, obviously, that is not a very big joint so a movement. उस जगह पे जिस सिर्फ पेशेंट को on the ground या just off the ground on the in the resting area वहां पे ही उसकी जो है रिडक्शन हो जाती है. रिडक्शन को मेंटेन किस तरह रखेंगे वहां पे एक्सप्लेंट जो है उनको पहनाया जाता है वो दिया जाता है जिसमें which will keep the PIP in flexion but they will block the last 30 degree of PIP extension क्योंकि उसको जितना PIP extension मिलेगी they will be no such healing, they will be stretching up the polar plate. इसलिए उसको थोड़ा बहुत जो है इसको फ्लेक्स पोजीशन में रखना है ताकि पी जो ओलर प्लेट है ये जो है वहां पे इसकी हीलिंग हो जाए. दैट्स वाई द लास्ट 30 डिग्री ऑफ द एक्सटेंशन ऑफ द पीआईपी जो है, इसको थोड़े से ब्लॉक किया जाता है। अगर इसको अनट्रीट रखा जाए, सो वहाँ पे इनको एक्सटेंशन में रखा जाए और ये स्प्लिंट नहीं दिया जाए, तो यहाँ पर एक्सटेंशन डिफॉर्मिटी हो सकती है, और somehow वहाँ पे that may lead to the instability as well. We can see here these are the dislocation, the dorsal dislocation, और यहाँ पे ये जो dislocation हुई है, at this side there is polar palate. So obviously if there is so severe dislocation at this joint at the PAP, so ये जो वहाँ पे polar palate है उसकी डिस्ट्रक्शन होगी, एंड दैट्स वो इसको फिर हमने फ्लेक्स करना है ताकि ये जो डिस्ट्रप्शन हुई इसको थोड़ी बहुत जो है हो जाए। यहाँ पर भी हम देख सकते हैं, दिस इज द राइट वन, दिस इज द लेफ्ट वन, एंड दिस इज द, इसी तरह हम उसकी करते हैं, रिडक्शन करते हैं कि थोड़ा हम उसको पहले ट्रैक करेंगे ताकि इफ देर इज ओवरलैपिंग आ गई है, ओवरलैपिंग को ठीक करने के लिए थोड़ा सा हम पहले ट्रैक्शन अप्लाई करेंगे। ट्रैक्शन के बाद ऑन द प्रॉक्सिमल साइड जहाँ पे पीआईपी जॉइंट है, ऑन द डिस्टल यानी मिडिल फेलेंस का जो बेस है उसके ऊपर थोड़ा सा ओलर प्रेशर अप्लाई करेंगे, और उसके बाद जो है दैट विल बी रिड्यूस्ड। सो दिस ट्रैक्शन इज वेरी इंपॉर्टेंट। और चूंकि ये पीआईपी जॉइंट में अमूमन जो है ये डिस्टल फेलेंस मिडिल फेलेंस इस डिसलोकेट हो जाता है, जबकि प्रॉक्सिमल फेलेंस अपनी जगह इसलिए है, वी हैव टू मोबिलाइज एंड वी हैव टू रिड्यूस द मिडल फेलेंस। और ये ट्रैक्शन और ये डार्सल, क्योंकि डार्सल डिसलोकेशन होती है, सो दैट्स व्हाई हमारी डायरेक्शन ऑफ फोर्स जो है दैट विल बी इन द ओलर साइड। तो ये ओलर प्रेशर अप्लाई करेंगे और then they will be reduced easily. And then we can see here this is in the flexion, or patient is during this splint the patient is unable to extend this digit, और ये flexion इसलिए जरूरी है कि यहाँ पे जो structures which is been जो collateral ligament है या यहाँ पे ओलर प्लेट है, इसकी जो इंजरी हो चुकी है, डिस्ट्रक्शन हो चुकी है, ताकि उसको हीलिंग के लिए थोड़ी बहुत टाइम मिला। सो दैट्स व्हाई ये जो स्प्लिंट है that is used to block that darts block splints को कहते हैं, because यहाँ पे full extension the person is unable to do the full extension, और ये full extension इसको block कर, that's why this is known as the dorsal block splint. About towards the DAP dislocation, we have discussed the fracture of the MCP, the fracture of the middle phalanx, then the proximal phalanx, the middle phalanx, and then the distal phalanx. Then we discussed the dislocation of the MCP joint, then the dislocation of the PAP joint, and now the the dislocation of the DIP joint. So these dislocation of the distal interphalangeal joint that usually occur dorsally and are common associated with the ulnar skin laceration is often due to the ball hitting the finger and causing hyperextension. Reduction attitude by traction and flexion, as we discussed it previously, the joint should be splinted for 3 weeks in 19 degree of flexion, like we have discussed in this slide, where dorsal block splint is just used just to prevent that extension, not hyperextension, the extension. It means we have to keep them and prevent the last 10 to 20 degree of the that extension of these dislocated site. Collateral ligaments, they are very rare as compared to the PAP, जहाँ पे अक्सर जो है collateral ligament injury हो जाती हैं, but as compared to the PAP, the DAP dislocation में the involvement of the collateral ligament is very rare. Flexor tendon function must be assessed as the Volgin can occur with this injury. Uh, as compared to the PAP, जहाँ पे the इतना ये फ्लेक्सर टेंडन फंक्शन जो है ये पैथोलॉजिकली इन्वॉल्व नहीं हो सकता, यहाँ पे इसकी chances, that's why that should be assessed along with the reduction of the that DIP joint. The less common ulnar dislocation occur in the situation with the fracture and usually involve damage to the extensor tendon. So that is actually the dorsal dislocation. We can see here that is being. So again, the ulnar pressure will be applied, एंड हेंस यहाँ पे जब हम वहाँ पे पीआईपी डिसलोकेशन को रिड्यूस करने का तरीका डिस्कस कर रहे थे, तो वहाँ पर इसको हम ग्रैब करेंगे, इसको हम करेंगे एंड देन ट्रैक्शन देंगे। ट्रैक्शन के बाद जो है फिर यहाँ पे पोलर प्रेशर अप्लाई करेंगे। नाउ इफ देयर इज हाइपर एक्सटेंडेड डार्ट्स और डिसलोकेशन हो गई है, और जहाँ पे यहाँ पे हाइपर जो प्रॉक्सिमल फेरेंज है उनकी हाइपर फ्रिक्शन हो जाएगी। तो इस सूरत में हमने पहले थोड़ा सा जो है ग्लाइड देना है, ट्रैक्शन देना है, ताकि इफ ये जो ओवरलैपिंग हो गई है, इस ओवरलैपिंग को हम थोड़ा सा वापस करें और ओवरलैपिंग को अनडू करें, और जैसी ओवरलैपिंग खत्म हो जाएगी, ये दोनों जो स्पेस जो जॉइंट्स रिकॉर्ड स्पेस है वो आ जाएगा। फिर यहाँ पे हम क्या करेंगे, थोड़ा सा उसको इस डायरेक्शन में अप्लाई करेंगे, while we will try to just push them in the interior direction, in the other direction, which will lead to the reduction of that joint. So we will apply pressure with the thumb on the proximal aspects of the dislocated phalanx. जबकि we will push the phalanx into an anatomical position like we can see here in this picture. So that was all about the fracture and dislocation of all the regions in the hand. Now we will discuss the ligament and tendon injuries, or also we will discuss specifically the ulnar collateral ligament of the first MCP joint. These MCP joints, the first MCP joint, ulnar collateral ligament, or the medial collateral ligament, that is very common among the skiers. जब स्कीर्स गिर जाते हैं तो चूंकि जो स्टिक को यूज करते हैं, उनकी स्टिक में की जिनको हैंडल जो उसको पकड़ते हैं उसके ऊपर जो बैंड होता है, तो अमूमन उस बैंड में उनका थंब जो है ये फंस जाता है, जिसकी वजह से इसकी जो अल्नर कोलेटरल लिगामेंट है इसकी रप्चर हो जाती है। इस इंजरी को, इस जो अल्नर कोलेटरल लिगामेंट इंजरी है, इसको समहाउ गेम कीपर स्तंभ भी कहा जाता है। वी हैव ऑलरेडी डिस्कस इन द लेक्चर, जब हम डिस्कस कर रहे थे द स्पोर्ट इंजरीज, तो वहाँ पर हमने डिटेल से डिस्कस किया है इस इंजरी को कि व्हाई इट इज नोन एज द गेम कीपर स्तंभ, एंड बिकॉज ऑफ दैट हिस्ट्री जो एक स्कॉटिश गेम कीपर्स होते थे व्हेन दे वो ऑन ड्यूटी, और ये जब रेबिट को पकड़ते थे तो रेबिट को हैंड करने के बाद उनकी नेक को ग्रैब करके उसको ट्विस्ट करते थे, तो उसकी वजह से उनकी जो लिगामेंट है, क्योंकि वहां पर स्ट्रेचिंग हो जाती थी बिटवीन द थंब एंड इंडेक्स फिंगर, क्योंकि इसी एरिया में, यानी द एरिया बिटवीन द इंडेक्स एंड थंब, इन एरिया में उसकी गर्दन होती थी, तो उसको जब वो ट्विस्ट करते थे तो वहां से उसकी अल्नर कोलेटरल लिगामेंट ऑफ द फर्स्ट मेटाकार्पल जो है इसकी इंजरी हो जाती थी, और इस वजह से इसको गेम कीपर थंब जो है, दिस इज दैट अल्नर कोलेटरल लिगामेंट वी कैन सी हियर। तो इसका रेबेट का हेड यहाँ पर होता था, और ये जो उसको ट्विस्ट करते थे, सो देयर वाज रप्चर ऑफ दिस अल्नर कोलेटरल ऑफ द दैट फर्स्ट एमसीपी जॉइंट। इसी तरह जो है यहाँ पे उन्होंने ग्रिप कर रखा होता है हैंडल को, और जब वो गिर जाते हैं तो हैंडल के ऊपर यहाँ पर इसकी एबडक्शन हो जाती है, इस तरह की हाइपर एडक्शन हो जाती है। तो जब हाइपर एबडक्शन हो जाती है तो देयर इज मोर स्ट्रेचिंग ऑन दिस साइड, एंड हेंस इट इज आल्सो नोन एज द skier thumb. So skier's thumb or the gamekeeper's thumb, that is common, and it's actually there is grade 3 Hamuman sprain of the ulnar collateral ligament of the first MCP joint. So that we can and use the result from the first abduction and hyperextension of the MCP joint. The patient may complain of weakness of the thumb index pinch grip, and that's why this pinching, if we give something to hold them between the thumb and index finger, and then to call them just to pinch and just to force them, so there will be more pain on this side. There is a positive sign and positive test for the that ulnar collateral ligament sprain of the first MCP joint. There will be swelling and tenderness on the ulnar aspects of the MCP joint, और इससे पहले कि हम उसकी स्टेबिलिटी जो है उसको चेक करें, एक्सरेज जो है ये करनी चाहिए जस्ट टू एक्सक्लूड इफ देयर इज एनी फ्रैक्चर। सिमिलरली हम वहाँ पे उसकी थोड़ी सी रेडियस डायरेक्शन में उसको स्ट्रेस देंगे ताकि वहाँ पे स्टेबिलिटी ऑफ द लिगामेंट जो है ये कितनी है। पेन जरूर होगा, लेकिन वहाँ पे अगर यहाँ पे इफ देयर इज कंप्लीट रप्चर और द पार्शियल रप्चर इन बोथ केसेस दे विल बी पेन। Deviation within 10 to 20 degree of the non-injured side indicate a partial tear of the ulnar collateral ligament. They should be treated with an immobilization and a splint where the MCP joint and slight flexion for 6 week। और फ्रिक्शन इसलिए होगा क्योंकि जब ये जितना ये फ्रिक्शन में होगा उतना ही जो है दे विल बी लेस स्ट्रेस ऑन द अल्नर कोलेटरल लिगामेंट। अगर हम इसको थोड़ा सा एबडक्शन करें या इसको हाइपर एक्सटेंड करें, in both cases they will be stretching up this ulnar collateral ligament. So just to reduce stress on this ligament and just to give time for healing, the thumb should be kept in the MCP joint should be kept in the flexion position, and that is actually and for just 1.5 month, and that will lead to the treatment and healing of this MCP joint sprain of the ulnar collateral ligament। सिमिलरली इसके बाद जो है उसको कई कई हफ्तों तक यानी अप टू 12 मंथ तक उसको जो है प्रोटेक्टिव स्प्रिंटिंग जो है ये पहननी चाहिए इफ द पर्सन इज गोइंग टू पार्टिसिपेट इन स्पोर्ट। दिस इज द प्रोटेक्टिव स्प्रिंट हार्ट स्प्रिंट एंड दैट्स वाई वहाँ पे ये जो एमसीपी जॉइंट है फर्स्ट मेटाकार्पल and proximal phalanx of that on the thumb side. So वहाँ पर they will be a protection from the abduction or the hyperextension. The thumb may also be tapped with the index finger, which act as a less secure check ring to the prevent hyperabduction और body tapping between these two। तो लेकिन ये थोड़ा सा ये होगा कि इसमें फिर इसकी मोबिलिटी जो है ये काफी हद तक जो है रेस्ट्रिक्ट हो सकती है। और दिस इज दैट रीन टू प्रिवेंट द हाइपर एब्डक्शन ऑफ द थंब। सो इस केस में उसकी मोबिलिटी भी जो है मोबिलिटी भी जो है थोड़ी सी उनकी होगी और इसकी हाइपर मोबिलिटी यानी एक्सटेंशन एंड हाइपर एब्डक्शन ऑफ द एमसीपी जो है, ये भी प्रिवेंट होगी। So this is one of the best to use during the inactivity daily life। A complete tear of the ulnar collateral ligament sometime require surgical repair, and surgical repair is then necessary if there is sternal lesion। What is the sternal lesion? Because आगे हम discuss करेंगे जहाँ पे there is interposition of the extensor hood। A displaced avulsion fracture of the base of the proximal phalanx also require open reduction and internal fixation with these surgical wires, the Kirschner wire। अच्छा ये जो Kirschner wire है ये आगे डिटेल से डिस्कस किया था अबाउट द स्टेनर लीजन इन द प्रीवियस लेक्चर जब हम डिस्कस कर रहे थे स्पोर्ट इंजरीज में कि इसको किस तरह जो है ट्रीट किया जाता है और इसकी स्टेनर लीजन क्या होता है और इसकी मैकेनिज्म क्या है। सही। तो जब सर्जरी हो जाती है सो दिन द थंब इज प्लेस्ड इन स्पेसिफिक कास्ट ऑन द स्पीकर कास्ट फॉर एटलीस्ट 1 to 1.5 month। जा और इसके बाद जो उसको प्रोटेक्टिव स्प्लिंट जो है ये यूज करनी होगी फॉर मोर एंड मोर मंथ। दिस इज द मैकेनिज्म ऑफ द स्टेनर लीजन। वी कैन सी हियर this is the ulnar collateral ligament जो इसकी टीयरिंग हो जाती है। दिस इज द एडक्टर एपिन्यूरोसिस। और सम हम स्टेनर लीजन उसको कहते हैं कि ये जो डीप स्ट्रक्चर होता है लिगामेंट जो है ये डीप होता है और टेंडन एपिन्यूरोसिस जो है ये उसके ऊपर होता है। तो अगर इन केस ये जो कोलेटरल लिगामेंट है ये बाहर आ जाए और ये सुपरफिशियल आ जाए लाइक वी कैन सी हियर इन दिस जब वहाँ पे वेलगस स्ट्रेस होगा तो ये ज्वाइनिंग ओपनिंग होगी जिसकी वजह से उस ओपनिंग ऑफ द जॉइंट की वजह से दिस फ्रैगमेंट ऑफ द अल्नर कोलेटरल लिगामेंट they will just come out and will superficial toward the this epineuritis। This is actually known as the Stener mechanism। The adductor epineuritis slip past the proximal portion of the rupture ulnar collateral ligament। As the alignment returns to normal, the adductor epineuritis pushes the ulnar collateral ligament proximally to form the Stener lesion। ये देखिए और जब वापस अपनी जगह पर ये स्ट्रेट हो जाता है तो बजाय इसके कि ये वाला लेग ये स्ट्रेट हो ये उसको पोस्टीरियरली पुश करेगा यानी डॉर्सल उसको पुश करेगा। एंड दिस पुशिंग बैक एंड प्रॉक्सिमली यानी प्रॉक्सिमली जब इसको पुश करेगा, दैट कंडीशन इज एक्चुअली नोन एज द स्टेनर लीजन. तो यहाँ पे क्लियरिंग हो जाती है. आफ्टर द valgus stress they will be opening up the joint, and this turn part of the ligament they will just come out, and they will be make over the superficial to that epineuritis. And when जैसे ही वापस अपनी वेगस स्ट्रेस के बाद जॉइंट वापस अपनी पोजीशन पर आ जाती हैं, so the tendon epineuritis, they will push back, they will proximally push this torn ligament in that dorsally, and that is actually known as the Steiner lesion. Injuries to the radial collateral ligament of the first MCP joints, that is less common that as compared to the ulnar collateral ligament. But if there is complete rupture of this, again it is the reason for that instability of that area. Deviation of greater than 10 to 20% more than on the non-injured side with ulnar stress indicate a complete tear. As there is no soft tissue cut between the two ends of the ligament, so 6-week cast embolization is the treatment of choice. That will be discussed in the next session, inshallah. Thank you so much.